Well, I'd like to welcome everyone to tonight's webinar on applying the NYSDA Code of Ethics to real-world dentistry. To start things off, I'd like to introduce Dr. Stephen Cho, Chair of the Society's Ethics Committee. Dr. Cho is a board-certified oral surgeon in private practice in Manhattan. In addition to running a private practice, he is a clinical associate professor at Touro College of Dental Medicine, where he devotes his time teaching dental students. He served on the New York State Board of Dentistry from 2007 to 2017 and was vice chair in his last 2 years. Dr. Cho?
Thank you. Good evening and welcome. Tonight's presentation on applying the New York State Dental Association Code of Ethics to real-world dentistry will be both very informative and interactive. After review of the Code of Ethics, there will be a case-based discussion using ethical dilemmas. We hope you will pose questions and engage in discussion. It will be a lot more engaging if everyone shares their thoughts. This is a safe space for discussion. Now I will introduce Dr. Julie Connolly. Dr. Julie Connolly is a board-certified periodontist. Currently, she is in private practice in periodontics in Manhattan and is an assistant professor in periodontics at Columbia College of Dental Medicine. She is the director of ethics coursework at Columbia, teaching ethics and professionalism to dental students and residents. She lectures regionally and locally on dental ethics, periodontics, and periodontal microsurgery as well. She is the immediate past president of the New York Academy of Dentistry, the vice chair of the New York section of the American College of Dentists, a fellow of the International College of Dentists, a member of the Council on Ethics, New York State Dental Association, and the past president of the Columbia Dental Alumni Association. Let's welcome Dr. Julie Connolly. The floor is yours, Julie.
All right, thank you, Steve. It's so great to see everyone here tonight. The program that we're presenting is the brainchild of the NYSDA Council on Ethics. Within the last year, we welcomed a member dentist to the council who represented the New Dentist Committee. And as she sat and she listened to our council meetings, listened to the cases that we heard, she said, you know, I really think it would be helpful, particularly for younger dentists, but all dentists in New York State, to learn a little bit more about the NYSDA code, what's specific to it, but also the types of cases that I hear here. I had no idea. And so this is where the idea for this program came from. And so what you're going to see tonight, it's a collaboration of the council, of several members of the council and the full council working together to present to you applying the NYSDA Code of Ethics to real-world dentistry. So as we talk about just our goals for tonight's session, the first is to increase awareness of ethical concerns that can arise in clinical practice. The second is to provide an update for members on the NYSDA Code of Ethics. Many of us learned about the ADA Code of Ethics when we were in dental school, but tonight we're going to focus on the NYSDA Code of Ethics. Thirdly, we're going to provide a medium for discussion on how to navigate ethical dilemmas, and I'll talk about this in a little bit. Now, we are going to basically divide the talk up into two parts. The first will be a brief overview of the NYSDA Code of Ethics, and the second will be case review. And this is what Dr. Cho was referencing, where we'd like to get our attendees involved. We'd like to hear your thoughts, your opinions, any questions you might have on the cases that we present. And these are going to be ethical dilemmas based on scenarios and situations that we've seen at the council level in New York State. So within the NYSDA Code of Ethics, there are 6 sections. The first is entitled Service to the Public and Quality of Care, followed by a section on education, government of the profession, research development, patent copyrights, professional announcement, and judicial procedure. And there are subsections that are called statements within the NYSDA code, and they're basically advisory opinions or ways of translating or applying the code to real life dentistry, be it clinical dentistry, research dentistry, whatnot. Sorry, a little trouble with the computer here, hold on. All right, so in our first section, service to the public and quality of care. This section, it talks about the dentist's primary professional obligation being to the public, the competent, timely delivery of care given with due consideration to the needs, desires of the patient, and shall be the most important aspect of that obligation. Now, this is a very broad, very kind of all-encompassing of many of the things we do as dentists when we serve the public. As such, there are several different areas of focus that the code has. There are actually 13 of them. I'm not going to go through each of them in nitty-gritty detail, but I wanted to present a little bit about what the code does talk about. So in the first section, they talk about patient selection. So this has to do with the patients that we have in our practice not being prejudicial, being open, being fair with the patients who are in our practice. The next section talks about patient records. And this is our duty and our obligation to not only provide records when the patient requests them, but also to maintain the privacy and the confidentiality of such records. The third part talks about community service. So this is going beyond our own practices, but being part of serving the greater dental community. The fourth section is emergency service. This talks about our obligation to be available for our patients of record, but also not of record, in instances where there is an emergency both during office hours and even after office hours. The following section 1E talks about consultation and referral. And this is basically when we realize that we need somebody else's opinion or insight into a case, be it a specialist or somebody who has more experience in addressing the patient's needs, that we take that step and make the referral. In section 1F, we talk about auxiliary personnel. And this is what our staff members, our dental hygienists, our dental assistants can do. Many times this section is linked to the Dental Practice Act within our state, which gives fairly distinct guidelines on parameters of what these auxiliary personnel can do. Section 1G talks about justifiable criticism. So in this section, it's about what happens when you get a patient who's seeking a second opinion and you are asked to evaluate another dentist's work. Is this something that you're going to just do in a maybe an unjust fashion? Are you going to say things that could put down the other dentists? What is our obligation to obtain more information before saying things to the patient? This section explores that. Next section, expert testimony. So this would just define our obligations. Should we be called to be an expert witness, or to testify in a case? The next section talks about rebates and split fees. So what we are and are not allowed to do in this realm. Section 1J, representation of cares and fees. This is going to talk and go into two areas. One is going to be that we must represent care and fees truthfully to our patients, but that also is going to stretch into the area to insurance companies, to third-party providers, being truthful in how we represent both items. In section 1K, the code talks about patient consent and involvement. So this goes back to that concept of informed consent. And what does it mean for a patient to be truly informed and be able to make an adequate decision? You know, telling them about risks, benefits, and alternatives, who's going to perform the treatment, how much the treatment is going to cost, or some things that we need to consider. In section 1L, where we talk about patient abandonment, many times that's going to apply to a situation where you might be needing to dismiss a patient. And what are your obligations to ensure that patient has access to continuation of care, even if it's not within your own practice? And in section 1M, the code talks about personal relationships with patients. Now, this might be a patient who is your uncle, your cousin. This could be a patient who's your partner. Understanding that there's dual relationships that are going to go on, and there might be differences that occur when you treat a patient who is more a stranger than somebody who you have a personal relationship with. This part of the code explores that. Now, in the second section of the code, it talks about education. And this is the right of a dentist to professional status rests in the knowledge, skill, and expertise with which she or he serves his or her patients. Every dentist should maintain and improve his or her knowledge and skill through continuing education as required by state law. So when we think about this statement, it is our duty to be lifelong learners, right? That when we go to dental school, when we go to residency programs, our learning doesn't end there. And we have an obligation to best serve our patients by staying up to date with standards of care and by continually taking courses to make sure we improve our care. In the next section, it talks about government of the profession. And it talks about, as a profession, we owe society the responsibility of regulating and disciplining ourselves through the influence of professional associations. So professional associations like New York County Dental Society, like NYSDA, like the ADA. and that all dentists therefore have the dual obligation of making themselves a part of professional association, but also observing its rules of ethics, right? So saying we will abide by NYSDA Code, the ADA Code. One area where the code very specifically references here is peer review. As I hope all of you know, peer review is a quite significant member benefit that we have as members of New York County, NYSDA, and the ADA. And if as a member, we decline to participate in peer review, this would be taken as the code is written as a violation of the code and an ethics violation, because basically it means we're not willing to engage in that self-regulation process, that reflection. The fourth section is about research, development, patent, and copyrights. And here talks about dentists having the obligation to make their results of their research discoveries available to all when they're useful for the health of the public. Now, this is going to apply more to dentists who are involved in research than somebody who might be in private practice, but two areas of focus: therapeutic methods and devices, patent and copyright. Section 5 talks about professional announcement, and I can tell you that at the council level, we hear about issues related to this all the time. Almost every meeting, somebody in their component report will mention a complaint or an inquiry that relates to this section. It states, in order to serve the public properly, dentists should represent themselves in a manner that contributes to the esteem of the profession. Dentists should not misrepresent their training and competence in any way that would be false or misleading in any material respect. So there are 5 areas of focus within professional announcement. The first focuses on advertising. This used to be simple, right? You would advertise by putting something in print media, but now this applies to our websites, our social media, our blogs, that we have to be truthful in how we advertise ourselves. The second is with regard to name of practice in Section 5B, so that the practice name that we have should not be misleading to patients. Section 5C and D, they talk about how we announce ourselves as specialists, as general practitioners. And this should be truthful based on the skills and the education that we have had. And in Section 5E, talks about the use of specialty related terms. So terms should not be used to imply a certain specialty when one has not been obtained. Now in the last section, it's called judicial procedure. And this basically talks about what happens when there is an ethics violation. So the code states that notwithstanding any provisions of bylaws, an alleged violation of the principles of ethics and code of conduct shall be heard by the ethics committee of the component society in which the alleged violation took place. So this would be if the violation took place in New York County, then the hearing would be held here in New York County. But it's specific that the enforcement of the penalty is the responsibility of the component in which the dentist holds membership. So if they held membership in New York County, then the penalty enforcement would be within New York County. But if it was a Bronx County member practicing in New York County, then it would be the Bronx County that would enforce the penalty. And then it just briefly references that there are going to be guidelines that will be followed during these hearings and certain formats that will be engaged. Now, that is the summary of the NYSDA Code. At this point, we're going to segue into our ethical dilemma case discussion. In order to help this discussion, I'm going to do a very brief review of the 5 principles of ethics from the ADA Code, as well as critical attributes of professionals as defined by the American College of Dentists. Then as we start into our case discussion, we're going to use 3 different frameworks for discussion. The first will be open-ended. The second will be following something called the Protocol for Ethical Decision-Making. And the third will be following a narrative ethics rubric. The second and third frameworks are specific, and before we start each of these cases, we will review the structure and how we will have and guide the discussion. So, the 5 guiding principles from the ADA Code. Hopefully everybody remembers this from dental school. First principle, respecting a patient's wants and needs. So this is the concept of autonomy, right? Autonomy is involved with both informed consent, so the patient's decision-making capacity, being involved in decisions, but it's also with respect to confidentiality, privacy of the patient's records. Secondly, doing no harm. This means this concept of non-malfeasance. So we should not harm our patients, but we should also work to prevent them from harm. Within this section, the code talks about our ability to stay competent. It talks about making sure we make referrals when we need to, if things are out of our scope, making sure that our auxiliary personnel perform the appropriate care as defined by the Dental Practice Act. It talks about what to do if you are impaired or you have a colleague who's impaired. This all falls under the jurisdiction of do no harm. In the section on doing good, this is beneficence. So this is acting for the very specific needs and benefits of your individual patient. This is also looking at the greater societal level to do good for the greater patient community. The fourth principle is being fair. So this is talking about justice, right? And this is absolutely with respect to our patients, but also with colleagues in society. The fifth is to be truthful, and this is exhibiting veracity, right? That we're being honest, we're being trustworthy with all the different folks that I talked about. This could be with our patients, our colleagues, our staff members, could be with our insurance companies. We have obligation to be honest. Now, the American College of Dentists, this is an organization, national organization that has been around for over 100 years now, and their focus is on leadership, ethics, professionalism. And they have a lot of programming and information guided towards this concept of professionalism. And they feel as a professional, you should have respect for human beings, be competent, have integrity, and be focused on service over prestige or profit. So I'd ask that as we talk and go through the cases that you keep these concepts in mind, both the guiding principles from the ADA Code as well as these critical attributes of a professional. So as we move on to the first case, this is a case about emergency service that will talk about Section 1D in the code. And this is an open-ended format. So I'm going to ask our Ethics Committee Chair, Dr. Cho, to read the case for the group. And he will also just briefly talk about parameters as we start our discussion.
Okay, so the first case or the first ethical dilemma is basically, as Julie mentioned, it deals with the service to the public and quality of care. Again, this is an interactive program, so please engage in conversations, and so this way we can have a good discussion. So the first case, you work in a group practice as a general dentist. There are several oral surgeons in your community that you refer to for surgical extractions. Recently, you have started to hear complaints that the oral surgeon, Dr. Wisdom, has not been available for patients with emergency problems after hours. They have reported that on weekends or at night, the only option is to leave a message on the office voicemail to be checked the next business day, and no way to page or call the doctor directly. There is no information provided on what to do in case of emergency. This has left these patients to call you late at night and on the weekends instead. You are happy to try to help these patients. However, you are not an oral surgeon and do not always have the expertise to manage their problems. You tremendously respect Dr. Wisdom's clinical skills and experience. He is well known and an influential figure in your dental community. However, you know he should be available for these patients' emergent needs, both during the workday and after hours. You now find yourself in an ethical dilemma. What do you do?
All right, thank you, Steve.
Thank you.
Okay, so with this case, I just like to ask the group if anybody has any initial impressions, any initial reactions when hearing the case.
Okay, I'll say something.
Thank you, Gail.
I just want to say that my daughter just finished dental school a year ago, and she's finished her residency program, and she had exactly this happen to her. And it's interesting. So this is not just, something that, just someone thought about. This really happened to her. And it was one of her attendings from her residency program. And she had she had the oral surgeon's cell phone number, and it was very difficult to get in touch with the oral surgeon. And the patient was really having a big problem. And so this happens. This is not just, imaginative, just to say that. I'm not going to say what happened.
All right, thank you, Gail. Yes, one thing I should mention that this case, while is based on an article that our current or a NYSDA member, Kevin Hanley, wrote in the NYSDA Journal. And it was something that he had experienced within his community that he wrote about. So if you're interested to learn more about his specific situation, the reference is at the top of the slide on the upper left. So yes, this is something real that definitely does happen.
I would like to chime in.
Please
I
do.
don't understand why the general dentist doesn't have a backup plan to seek and being in contact with another oral surgeon in either in adjacent community,
Right.
so that the lines of communications are clear and he can refer patients to another oral surgeon within a reasonable distance.
Okay, so thank you. So you would like to see this general dentist
Have a backup plan.
have a backup plan, basically. Okay, great. Thank you. Thank you, Ron.
I have a comment to make.
Yes, please.
Yes,
Go ahead, Dr. Monte.
yes, we are back in.
I think he might be having some IT trouble. Are you there, David?
Yes, we're going back and forth. Go right ahead. I just want to mention.
I think we're having some technical difficulties with Dr. Montehaney.
Yes, can you hear me now?
Yes.
All right. I think my comment very straightforward to what Dr. Shupak mentioned earlier. This is not an aberration. And 40 years of practicing in New York City, I have seen this many times. And this is specifically related to solo practitioners. I don't see that much with the group practitioners, but with the solo practitioners. And the issue is not what the general dentist should or should not seek for alternative. Is the responsibility of surgeon to have some sort of, backup for the emergencies. And that is true in Dr. Connolly, your field in periodontal surgery. When you operate on a patient, you have to have a methodology to back up these patients for the emergencies. So having said that, the question was what we do, or what I would do if I'm a general dentist in a neighborhood. I try to approach Dr. Winston and mention to him that this is an issue. And if it's not addressed, I will report that, clinician, because this is a breach of the fiduciary responsibility of the clinician to take care of the patient in an emergency situation.
Thank
So
you.
I agree with you, Dr. Montehaney. Just from a personal experience, I had a practice with partners and associates in the office. But just recently, as all of you, I don't know if anyone, I'm an oral surgeon in the city, but just recently, my practice has become solo practice. I'm the only practitioner in the office. And one of the dilemmas that I had is every time I want to take some time off and I want to go to a lecture or go on vacation or for whatever reason, I need to take time off. It's very, very stressful because, as you mentioned, it is our duty and obligation to provide continuity of care to our patients. So the way at this point, what I do is, obviously you have colleagues, you make friends with your oral surgery colleagues that can cover for you, and you cannot provide or send patients to other practitioners that are not equivalent to your specialty. So I cannot have a general practitioner cover my office when I'm away. So in order for me to get coverage, what I do is I ask other oral surgeons in the neighborhood And before I leave or before I do anything, I contact them. You know, I'm telling them that I'm away for a couple of days if you can cover for me. And in my case, it has not been an issue, but it's very, very important that you don't neglect the patients and you provide, you know, there's some sort of a continuity of care.
Yeah, Steve, can you hear me?
Yes.
Steve, I listened to the discussion, and for me, you're all correct. But I think the first line, what I would do if I were had this problem, I'd speak to the oral surgeon. I mean, I'd call him up and say, hey, you know, Joe, I need to have a word with you because I've been having some issue where my patients are unable to reach you at off hours. It's really important. I'd like to maintain our relationship. I want you to take care of my patients as you have been doing, and I thank you for that. But there is an issue here with patients calling me now with complaints, and the complaints are legitimate if in fact you're not available. So let's have lunch or dinner, whatever, and let's go over this and figure out what's up so that we can continue with quality patient care. And at the same time, you're able to make sure that you're covering your emergency problems or off-hour problems. You got to talk to them. You just don't duck it and go do something else and say, well, how can I skirt around it? Yeah, we all can skirt around it. But rather than do that, I think that the individual should be spoken to in a nice way, not argumentative, but in a nice way. First of all, it's for his or her own good. They're supposed to. The laws require you to provide emergency care. And if at the best you can do is an answering machine, that's not good enough. It's just not good enough. So you have a conversation with him and make suggestions. See what he says, he or she. I have to learn to keep saying he or she. Well, but I think it's very important that you speak to that individual. I know you're not a DP. I understand that because you and I were partners for many years. I do understand it, but I'm just saying I don't care who it is. Any specialist, or any person needs to. We take great pride in our field, not only our special field, our general field. We all need to be available for patients when they need us. May not like it at 2 o'clock in the morning, but that's the way life is. And so arrangements have to be made. And the oral surgeon who especially operates on a patient relatively recently, without question, should be available. Got to talk to him or her, whoever it is.
Yeah, I think Dr. Rubenstein raised his hand. So Dr. Rubenstein?
I think our president, Dr. Jackson was first.
Okay, sorry.
Lois,
I apologize for not having video, but it's clear that when you refer a patient, you retain responsibility to that patient. So
Right.
it's important that you know who you're referring to and that you make sure that that person will in fact take care of emergencies in the appropriate manner. That said, once they're not, it behooves you to find appropriate care for your patient with another practitioner of the same level to deal with that emergency. So you still remain in this loop while this is happening. You have to make sure the people that you refer to are responsible. And you have to remember that even though you referred this patient out, they're still your responsibility and you have to do the right thing by them.
Thank you, Dr. Jackson. Dr. Rubenstein.
Yes, hi. I just wanted to add on a little bit to something that Jay said, which I totally agree that a lot of times with these ethical things, it comes down to a problem in communication, or that's a part of it. We all have our ideas of how we're taking care of our patients. Now, some things are obvious, but we're often inhibited to pick up the phone and talk to somebody when there's a problem because it can be an uncomfortable phone call, an uncomfortable thing to do. But I just almost always that's the first line of defense against things going awry, I think, is pick up the phone and call something. The very worst off you can be is no better than before you picked up the phone.
All right, thank you, Dr. Rubenstein. I see Dr. Walks has his hand up also.
Sure. It could also be a very easy first conversation to have where it's just a matter of, hey, I don't know if you're aware, but I've heard from several patients that they're having trouble reaching you after hours. So I don't know if there's a problem with your machine or how they reach you, but some of the patients were upset. So, I think it would be important for you to just check this out, make sure they can reach you, because obviously it's not good for your practice if they can't reach you, and it's not good for the patients. And then if there's a problem after that, you can start with the benefit of the doubt. Then your conversation might need to be a little more pointed, but you can start very easy and very, in a not challenging way and have that initial conversation.
So Dr. Watts, just to continue, let's say you do have a conversation with the practitioner and he still goes on his current ways. Then what would your next step, or how would you go about resolving the issue?
Okay, just disclosure, I'm also an oral surgeon. I was solo practice for a long time. I covered myself when I was on my cell phone all the time. And if I was away, sometimes I would take my calls, but I had someone back up who could see a patient if they needed. And if I was further away, whatever, I would have someone getting the calls directly. So I would have it covered. But if nothing happened after that first initial phone call, then you'd have to get, I hate to use the word, but a little more aggressive or a little more challenging, and just saying this is really a problem. Patients aren't getting the care that they deserve, and I won't be able to refer to you anymore unless this is taken care of. I would go that route. Also, just to fair game and turn around, as an oral surgeon, I used to get many calls from patients who couldn't reach their GPs about toothaches and everything else, and saying they had just gotten, a machine at the office, or no one was available for the weekend and were told to go to the ER by the machine. So it does happen in both directions, just to put that out there.
Thank you, Dr. Watts. Anything else that anybody would like to share?
Yeah, just the same thing. What Eric just said, he's totally right. I think we got many, many calls on weekends from individuals in general practice who said the patient, their machine said, "You're covering," and you didn't even know you were covering. You're covering, which is a little nasty and, of course, upsetting if you're not prepared to do so. We all chip in and help each other always, and many of us in specialty practice covered for our referral base, and even sometimes individuals we didn't know. And we dealt with it. But the whole bottom line is got to be available. If you don't want to be available, you don't belong in our profession. I mean, let's get straight about this. This is part of our obligation, just like being in the office on time to see your patients who are scheduled. Off hours is required to be covered and part of what we do. We're professional people. That's the bottom line.
Thank you, Dr. Goldsmith.
If Julie, if I could.
Yeah, go ahead.
Yeah, if I could just add and echo what Jay said, there were many instances too where I would find out from a patient that I was on call for a GP office.
Yeah.
I never minded if a GP would call and ask me to cover, and I would, but I would always ask them, well, if a patient needs a root canal, who would you like me to refer them to? Or if they had a complicated bridge that came off and broke, and I can't do that, who would I refer to? Unfortunately, many did not want us to refer to anyone else just because they were afraid of losing the patient. And I think it's also the obligation of the general dentist to make sure that their patients could be appropriately taken care of when they're not there.
All right, thank you. Thank you, Eric. So as we've talked about this case, just to bring it to the specific part of the NYSDA code that it hits, it's this Section 1D on emergency service. Dentists shall be obligated to make reasonable arrangements for timely emergency care of their patients by a licensed dentist. Obligated when consulted in an emergency by persons who are not their patients to make reasonable arrangements for emergency care. So again, patients both of record and not of record. And the code also talks about, should a dentist undertake emergency treatment of a new patient, the patient has the choice where to next receive their subsequent dental treatment and care. Okay. So with that, I think I'd like, if Steve is okay, to move on to case number 2.
Sure. You want me to read the second case?
Yeah, that'd be great. Thank you.
Can you put it up? Okay, thank you.
Okay, actually, before we read the second case, one thing I just wanted to mention is we're going to use a slightly different format to review this case. This is a format that we typically use with some of our dental students and residents, and it's called the Protocol for Ethical Decision Making. And it allows us to have a little bit more of a structured discussion that's more principles based. We'll ask first to confer and agree on the facts involved. So just restating the basics of the case. We're going to ask, is there more information you might like to hear about, right? Maybe the perspective of somebody who was not mentioned in the initial case. Is there information, past history you might like to know? Then we're going to talk specifically about what could we do. Then we'll talk about the ethical considerations, like those guiding principles I talked about. Consider the considered judgment of others. So where else could we go for guidance? And then we'll rank the alternatives and choose our course of action. So with that very brief review, Steve, the floor is yours.
Okay, thank you. All right, so second case. You're a new associate in the general dental practice, which prides itself on providing comprehensive family dental care. The senior general dentist in the office provides a wide scope of care, including Invisalign, endodontic, and periodontal therapies, and expects you to do the same. Today, you examine a woman in her mid-40s who presents with the chief complaint of wanting to have a nicer smile. Specifically, she wants to know what she can do to straighten her teeth with Invisalign. Based on your clinical exam, she has areas of minor caries, crowding of teeth along with several areas of buccal gingival recession and pockets up to 6 millimeters. Moderate bone loss is evident on her radiographs. The patient is a smoker. Based on your assessment, she needs initial phase treatment of scaling and root planing, as well as caries control. Once this is completed, you proceed with a periodontal reevaluation. You find deep pockets persist and the recession areas worry you. Concerned and wanting to make a referral to a periodontist, you consult a senior doctor who tells you to stop worrying about the gums and start the Invisalign already. She says that sending the patient to the periodontist means the patient will be lost for months and Invisalign will not start anytime soon. The patient is also itching to start her Invisalign treatment as well. You now find yourself in an ethical dilemma. What do you do?
All right, thank you, Dr. Cho. So here's our second case involving Section 1E of the Code, consultation and referral. So as you read the case, it's a bit long. We don't want to forget the important facts of the case. So I'll start out, but then I'm going to ask folks to chime in again. So we have a new associate in a practice with a senior doctor. It's a comprehensive practice, family practice. And we have a patient who has certain clinical findings, but also certain desires in terms of treatment. Are there any other facts that folks think might be important as we start to delve into this case?
Patient has periodontitis. Needs a referral to a periodontist.
Thank you, Gail. Right. And in that light, we have some conflict, right, between our senior dentist who doesn't necessarily see the importance of this and the junior dentist or associate who very much wants to make the referral. So with these basic concepts outlined, what else might you want to know? What might make your decisions on next steps more informed?
It's Jay again. I think it's important to know how much these areas the senior dental person is willing to take on. Maybe he just does scaling and root planing. I'm not sure. But this sounds like this patient needs more care prior to moving her teeth. So I think the logical thing would be, I think, the younger dental person is going to have to talk to the older person and just tell them that they're not comfortable moving forward with the treatment plan unless the foundation is taken care of first, which is perio.
Thank you, Dr. Goldsmith.
If the senior dentist is so greedy that he doesn't want to let any dollars walk out of the office, if it's above his pay grade to render competent perio care, he should invite a periodontist into his practice to perform adequate periodontal care so that subsequently the ortho can begin, but not beforehand. So
Right.
you challenge the senior dentist to bring in competent care if he doesn't want any dollars to walk out.
I think another piece of information that we can talk about that's not in here is, has this general dentist referred any patients to the periodontist? So maybe this is an issue with this practice in general, and it's actually a female dentist in this case. So maybe she never refers anybody out. And that's something that the new associate should be aware of.
Is this a case where do you think that the associate dentist, is there some sort of an obligation to refer out, or is it something that you kind of ignore and continue with the therapy?
The obligation is to do the right thing for the
patient.
Patient. That's it. That's it.
Right.
Period.
That's it. Starts there.
That's it. And it ends there.
Right.
So what is the obligation?
To treat the patient correctly.
Right.
Actually, the first obligation is to inform the patient of their condition. I'm not sure, has that been dealt with? Does the patient understand what can happen
Correct.
to them if they have orthodontic treatment without, we think about this as a conflict between two doctors deciding we should do this, but really if you inform the patient, they might just make the decision for you right there.
No, you have to inform the patient, but you're right, Mitch. You have to educate the patient so they are aware of the correct sequence of treatment.
I agree. And you know what? Even if the patient wants Invisalign and has periodontal disease, that doesn't mean that you have an obligation to treat them with orthodontics. So you have an obligation to do the right thing. Even if the patient wants you to do orthodontics on them with periodontal disease, it's not your obligation to treat them with orthodontic treatment.
It'll be catastrophic.
Well, unless the senior dental person does serious periodontal treatment, she has to ask, maybe because some of them are more aggressive today than years ago. And so I think that the junior has to ask the senior just what their comfort level is. Would she like to take over this care and take care of the periodontal problem?
But if
rather than sending it out. If they can't agree to it, that's a real problem.
But if you reread the case number, it says here, the senior doctor tells the junior doctor to stop worrying about the gums and start the Invisalign already, meaning the senior doctor is too impatient and too money hungry to do the right thing. So obviously he himself or she himself is not able to render adequate care, nor there's in-house periodontists to perform adequate care.
I have a comment, if I may.
David, actually, I'm going to ask you just to hold for 1 second because Eric just put up his hand before you spoke. So just 1 second. Eric, he's there.
He's muted.
Okay, I had trouble unmuting. Now I got it. Okay, I just think the other thing to consider is, everyone's point is well taken, but this junior person, I think it's time that they start looking for another job. I'm sure this case isn't the only case that is going on like this. I think there's a certain behavior that the senior person has, and I think it would show through in other cases, be it ortho. I mean, this case could be done the same way with the perio and crown and bridge, with the perio and implants that are going to be done adjacent to teeth that aren't in good shape. So there are two things here. Obviously, the junior person is worried about being let go, but is also, concerned and trying to do the right thing. So they're going to have to start being ready to make a move and also decide what they want to do about the senior dentist. So.
Exactly.
Right.
David, you were next.
Yes, I think the format of this question is the individuals who wrote this up wants us to put ourselves in the position of this young dentist who probably have a significant, loans from the schools, but he has a good education. He or she knows what is the right protocol and what the sequence of treating the patient for elective procedures like Invisalign. When Dr. Goldsmith, mentions, the baselines, the foundations of oral health is not there. So she knows her stuff. So the ethical dilemma is what she should do. And the question is what we would do if we were in her position. And I will tell you what I would do. And despite the fact that I may have a significant loan from the schools, I feel that my boss, the older gentleman, is unethical. I will not trash my profession, my education, and I seek, depart from that practice because this is a man who put, the profit in the head of the patient's welfare. That is not what we teach in dental school. So apparently, the ethical dilemma is very, very clear, not to associate with someone like this who have no ethics whatsoever.
What would be your responsibility to the patient? As you're the examining dentist, is there anything that you can tell the patient?
I would say my responsibility to the patient would tell them what I really, really believe and encourage them to get a second opinion. And I would get the hell out of that office as soon as I can.
Thank you, David. I mean, I think we've naturally went from asking for additional information to talking about options, and they're really wide ranging. And I think we can see that. And I think it's important for us to realize that as we think about what we could do in any given scenario, we want to think about not just what might make sense, but also what might be a little bit more out there on one end of the spectrum and the other. Because I think the more we think about the different options, the more we can become firm in what we need to figure out to take or what we want to do ultimately. So as we think about these alternatives that we've put out there, would somebody like to suggest what might be one or two of the more critical ethical principles in this case? Is there something or one principle that jumps out over another?
The first thing, do no harm. That's right. Do no harm.
No harm. That's it.
Any others?
Look, we've all spent so much time learning and continually learning, I should say. We don't really ever stop. We know what's right and what's wrong. There are times like this where you have to decide. This was more well, maybe it'll be common in the future. I can't say, but certainly it was common years ago where a lot of the general dental people, in spite of new technology and a lot more new learning, they would tackle anything. I don't mean to be unkind, but there were many of them that were older, set in their ways, sure that they could handle most things, also did perio, but what they did with perio was not what's done today and what's necessary today. And so it happens sometimes that the young doctor just can't manage with that particular older person. And they have to find a new job, which is true. The bigger problem is with these big groups where they're told what to do. That concerns me more than this. This does occur once in a while. Usually you can make it work by letting the older doctor do the perio. If he's that confident, wants to do it, say, look, I need you to do this because I'm not comfortable doing X, Y, Z, and I know you don't want to lose the patient. So let's work together and see if we can make this work.
Yeah, I think that's a good idea. I think having a discussion with the owner dentist or the senior dentist, discuss the findings, and in order to make this treatment work and do no harm to the patients, it's almost imperative that this patient gets a specialist consultation, right? Until the patient has a specialist consultation and pretty much has the go ahead from the periodontist, the orthodontic Invisalign treatment should not commence at all. But maybe if you have a discussion with the senior dentist and just kind of give your reasons why this case will be a failure or it's not going to be a benefit to the patient, maybe he may have a change in heart and his thought process and his practice may start to change a little bit.
I should just point out that Dr. Connolly lost her Zoom access for the moment. So
I'm back.
Oh, you're back?
I'm back, yes.
Okay.
Sorry about that. Spectrum has been an issue in my building today. Okay, I see the other Dr. Connolly has his hand up.
Oh, thank you. Yeah, a great discussion. I just bring it back to the, you asked what the key ethical principles are, or one in particular. and while I think a couple jumped out, non-maleficence or doing no harm, protecting the patient from harm, which, under the ADA code also includes knowing when to refer, I think is a particularly important one. And the next, and we've heard this over and over in the discussion, is autonomy and informed consent. It's got to let the patient help in on the decision making. Thank you.
Thank you. Yeah, and I think hand in
Yeah,
hand.
but the patient can't decide without us helping them, understanding the problem. So you have, it's not just a question of saying, okay, it's up to the patient. We have to lay this out for the patient one way or another, even if it's a little uncomfortable, and say, you need this treatment, here's why. It's important, explain why. And then I would think that most dental people, if the younger person goes to the older doctor and makes it clear that they're not comfortable doing something, but it has to be done. If he wants to do it and he's comfortable with it, okay, they can keep the patient in their practice. But we can't, look, we're bending over backwards here, trying to make it work. Bottom line is, our obligation is to whom? It's the patient, and it'll always be to the patient. We have to do that.
Yeah, I think when we look back to the ADA code and we look to their seal, at the bottom of the seal, it says putting patients first. And I think that's really what this is about. And just to bring one more principle into it, I think tied with informed consent is that in order to make a proper informed consent with your patient, allow them the proper informed consent, is that we have to be truthful. And so it's that concept of veracity. Even though the senior dentist seems to think that we're not going to inform the patient and be truthful, really that's a violation of those two principles. And I think we also have to remember we owe it to the patients to be accountable and be responsible.
That's right.
And that would be very challenged in this situation. Now, the next step in this protocol for ethical decision-making is determine the considered judgment of others. And that might be calling up and speaking to somebody at NYSDA, getting an advice or opinion from a colleague. It might mean also looking at the NYSDA code. And so I just wanted to share with you the next slide, which talks very specifically within the NYSDA code about consultation and referral. And they talk about the dentists having the obligation of seeking consultation of those with special skills, knowledge, and experience whenever the welfare of the patient would be safeguarded or advanced by such consultation. And they break this down a little bit further with 2 additional advisory opinions. But this really comes back to, I think, everything that our conversation has hit on very nicely. With that, ultimately, we would have to make the choice of what to do. I think we've seen a lot of good options arise. And sometimes it's difficult. We get a lot of options and we may need to rank them to figure out what we feel might be the best so that we're protecting our patients and making sure they're put first and their needs are met. As we wrap up this case, I know Susan and Golia had somebody had put something in the chat. Susan, would you be able to read that?
Sure, it's from Dr. Belloc, and he said perio requires a consult with a specialist in order to get permission to start ortho treatment. The general dentist and the periodontist should then discuss how to coordinate treatment for both plans and then discuss with the patient.
Okay, great. Thank you, Susan. All right. Any other parting thoughts before we move to our last case? All right, seeing none, then let's go to the last case that we have for tonight. This is case number 3. We're going to approach this using a slightly different rubric. It's called a narrative ethics rubric. When we talk about ethics from a narrative perspective, it's really based on the concept of storytelling and empathy, putting ourselves in somebody else's shoes, trying to gather somebody else's perspective as we try to figure out how to assess or deal with a dilemma we might face. And there are a series of questions that are asked. The first is, who are the stakeholders? So this is when you listen to the story, think about who are the people who are the critical actors, the critical players within the story. And then you want to ask, was harm done to anyone? Some people may have had a good outcome. Some people may have had a poor outcome. Rate that. And then we want to consider from the opposite end. So as the beholder, that would be you or I who are listening to the story, or even the narrator in the story. How does it make you feel? Do the circumstances give the perception of an optimal outcome? After we've been able to process our more emotional reaction, a more gut reaction, then we take the time to think about ethical concerns, violations of principles, professional lapses, etc., from the story. And from the narrative perspective, the way a case is concluded is by considering how we could rewrite the story to get a better outcome for all of the stakeholders or actors in the story. So with this perspective, I'd like to ask Dr. Cho to read the last case.
Okay. Dr. Smith calls New York State Dental Association and says that he has been working very closely with Dr. Jones over the last 20 years or so. Lately, Dr. Smith has noticed that the patients are coming back to him with really substandard care performed by Dr. Jones. In a prior conversation, Dr. Smith was told by Dr. Jones that he has been diagnosed with dementia and is being treated for such with medication. Dr. Smith wants to know what his obligation is as far as reporting the substandard care performed by Dr. Jones, which he does not want to do because he is friends with Dr. Jones. However, he knows that patients are at risk, not just his patients, but all patients that see Dr. Jones. Obviously, this is a very uncomfortable situation for Dr. Smith, and he doesn't want Dr. Jones to be disciplined. But he knows that the welfare of his patients are at risk. How should this case be handled ethically?
Okay, thank you, Steve.
You're welcome.
So for perspective, this is a case that actually our council's liaison at NYSDA experienced. She had a call that dealt with this very issue. And so she helped to write this case. And it was a case that came recently, or a call that came recently within the last few months. So as we consider this case, who are some of the stakeholders involved? Who are some of the key actors?
Well, you have the two partners, and then you have all their patients. But I make a suggestion because this is not that unusual. Now that I've gotten a lot older, I think that if Dr. Smith has noticed this, that it would be kind and considerate to speak with the family physician, tell him this is confidential, speak with the family physician and get some guidance, rather than going, you can go to the dental people, but they're only going to be able to help you so much. This is a medical problem. And I think that the first thing to do is speak to their family physician about it and start there and see what their feeling is about it, because they're used to handling these patients more than we are. Now this person is a patient, even though he's your partner, he's also a patient.
Thank you, Dr. Goldsmith. So I think also to consider, oh, I see Dr. Wachs has a hand raised, so I'll let him speak.
Yeah, I agree with Dr. Goldsmith. The only issue is the physician's hands will be somewhat tied by his HIPAA obligations, but it might be that when you bring this to the physician's attention, he'll have that information, he can work with that. I think you do need to talk to the other dentist. And I think if you're getting nowhere with that, it might be a matter of, getting family members if there are available.
Right, exactly.
Yeah,
Exactly.
speaking to the wife, children, someone else, and who can also hopefully understand the risk that this dentist is, taking to himself, his livelihood, his practice, and his patients. And he probably will need to stop practicing either way, but you'd still want to mitigate that risk. So I think you might look for allies in this situation who can help you out.
All right, so as we can think about options that we have, we also want to ask based on the story, and I think Dr. Wachs just alluded to this, has harm been done? Is it the potential for future harm, and is the harm that has been done? That's something to consider here. I think I saw somebody had their hand raised.
I think it's Dr. Connolly.
Oh, okay, so other Dr. Connolly, please.
Yes.
Oh, thanks. just, I mean, just coming back to the rubric, I mean, we can't forget about the key stakeholder in all of this are not just Smith and Jones, the two practitioners, but current patients and certainly future patients come into play. And we've got to consider that harm has actually been done at this point also, to the existing patients having had substandard care. Thank you.
Thank you. So as we consider the outcome of the story, I think folks would probably agree that it's probably not so great for both of the dentists. The dentist with dementia may not be aware, but surely there is harm that can be seen by his dental colleague. And the patients clearly could be suffering or could suffer in the future. So as you hear a story like this, how does it make you feel? What's your reaction to it?
Most psychiatrists will tell you that patients who have dementia have an idea that they're not well. They may not use the word dementia. They may not fully understand what their problem is, but they know they're not well. They know they have some kind of a problem. So it's not a total surprise if, in fact, a discussion has to be had. I just said, start with the physician. Look, it's a problem. So you want to get the medical people involved as much as they're willing to do. And of course, the family. And we've all seen dental people practice longer than they should, without mentioning names. We've all seen it. It's difficult. And sometimes you talk to them and they say, no, I'm fine. And they're not really fine. And but we're not with them all the time. It's just individuals who we know. If it's your partner, it's particularly difficult. So I would just start off first by just talking to the physician about it and then going from there. And if you're very friendly with the family, I think you have to do that too. You're going to have to speak with them because you're going to need some help in engineering to very gently let this individual know that it's time to make a change.
Thank you, Jay. Dr.
How about obligation to the patients? Let's say the practitioner is from another office rather than working together, and you see substandard care. You're treating all these patients from doctors, someone else from another office. How would you handle it, and what is our obligation to the patients, and how would you relay that the care is substandard without really creating issues with the other practitioner, or are you obligated to report the practitioner because he is providing a substandard care?
Well, again, you talk to the practitioner. If the problem is if you get nowhere with a discussion because they don't want to talk to you about it, or they're in total denial, that's a big problem. Then if you happen to know, again, you may not know the physician, but you may know the family, because your next move after that is to protect the patient, which means you're going to have to ask our organization for help in dealing with this. Yes, we have an obligation to the patient, no question. First, try to see if you can get the individual to recognize he has a problem and get treatment. Even if it's not your partner, it's still a good thing to do. Keeping the patients in mind. You can't start to, because the state has to do the same thing too. They're going to have to go through a whole process in order to take this patient out of the dental environment. It's not so easy to do it. So, but they do know, dementia patients know that they're not well. So it's not really a surprise. They're not going to be totally shocked. They know, they don't know what it is, but they know they're not well.
So I think one of the things that I'm sensing as I'm listening to the folks making comments is this is a stressful situation. This is an uneasy situation. It's even a sad situation, whether or not the colleague is your partner or somebody you've been working with for a short period or a long period of time. I think that we can really feel that there's not an optimal outcome that we have currently. And with that in mind, I think I saw that Susan Angolia said that there's somebody in the chat who had a comment.
Yes, the comment is that this situation also opens up a discussion on the definition of harm. All dentists have performed treatment that they are not proud of, so the profession has to approach this subject also.
Okay. Thank you, Susan. I think that is a great way to bring us to talk about the different ethical flaws, right? So harm has come up in multiple comments. And one of the things that you'll see as we talk about justifiable criticism, and I'll in a little bit bring up the section that the code refers to specifically, is this concept of, is it gross neglect? Is it negligence? You know, how poor is the care, right? There are gradations and the code talks about that, right? We all have done care that is not always ideal or perfect. So I think that the comment in the chat is very apt. I think the other Dr. Connolly had his hand up as well. I don't know if that comment was still.
No, that's fine. I think, no, I think Jay covered it very well. Thank you.
Okay, thank you.
Dr. Connolly, I have a comment to make.
Go ahead.
I think Dr. Cho brought, a general questions, and I want to just answer that, the broad way. If any of us observing a clinician persistently performing substandard care, I think not only is the issue of ethical dilemma, but also legal dilemma. I think legally we're obligated that we should step in and report that. It's no different than if you as a clinician to see a child abuse coming to your office, you are by law required to report that. If you see continually someone harming the patient and you have enough evidence, I think you're obligated not only ethically, but also morally and legally to report that.
Okay, thank you, Dr. Montahini. I think that we see in this case, a balance and a challenge, right? We want to do no harm to our patients. We have a colleague, though, that we have fidelity with, that we have a loyalty to, that we care about, and we have to balance how we make sure we safeguard our patients' health, that we ensure that no harm is done, while also respecting that relationship that we have with our colleagues and making sure that justice is served both to our colleagues, but also to our patients. So as we wrap up this case, how would you rewrite the story?
Before you go there, Julie, I have one quick question for you. Could you define the word mistreatment?
Right. So I think that goes back to this concept of justifiable criticism, about seeing negligence. That is, I'm just going to scroll back here. That is potentially repeated, that is gross negligence, that is not following standard of care. Okay. That is what you'll see typically within the code, especially the ADA code as well. With respect to this case, specifically refers to justifiable criticism. So what the dentist who is having these questions about the competence of his colleague, what does he say to the patients? It talks about being just and being truthful in remarks to patients.
You as a specialist, if you see a patient for the first time and as a periodontist, if let's say some crown and bridge was inserted and you witnessed some periodontal disease that was not addressed, are you calling that mistreatment or negligence or what? Or as an endodontist, if I see a missed canal and the patient is symptomatic with a residual radiolucency, is that mistreatment? Or as a restorative dentist, if a new patient comes and you detect open margins, is that a mistreatment? I'm asking.
Well, I think you need to have further information in the individual cases to get a little bit more history about
So
what
the word
happened.
mistreatment is ambiguous.
Yeah, right.
So I am part of the OPD, and the way the OPD looks at mistreatment, if you get a case with a crown with an open margin, and it's just one single crown, and someone complains because the crown didn't last, for so long. After a couple of months of insertion of the crown, the tooth had to be extracted because of an open margin. The OPD will look at the case. It's very difficult to say that's below this. It is sort of substandard care, but they're going to look at all the other circumstances why this did happen. I think if the practitioner has multiple episodes of open margins, then they will be disciplined for it. But sometimes if it's just one case, because a lot of cases you can have open margins and the practitioner has absolutely no idea that there was an open margin at all. So, I mean, each case is individual and you have to look at it carefully. But if a practitioner has multiple complaints with the OPD department, then they will take that seriously.
Thank you.
Thank you. Thank you. Dr. Rubenstein, I think you had your hand up.
Yes, I was thinking about this this issue of the way we criticize each other and what we can judge and what we can't, because I mean it's very easy to look at a patient and examine them and see what's wrong, but what led up to it is sometimes not as clear. It's very easy to say, oh, it's an open margin. This was done badly. I remember I have a patient of mine that disappeared. I had a crown that I placed. I tried it in and we took an x-ray. Margin was open. I mean, it was pretty good, but the margin was open. So I took a new impression, but I used the existing crown as a temp and the patient never came back. So called him, he disappeared. So somewhere out there, he's walking around with my crown with the open margin, and maybe he'll sit down in somebody else's chair and tell him, oh, Dr. Rubenstein, he's a putz, he left an open margin here. Didn't he say anything to you about it? I mean, we don't always know everything that we need to know. Sometimes I find it easier to kind of deal with the patient with what their problem is and what needs to be done to fix it, and not as much as whose fault it is as part of the patient treatment. I might have to deal with another doctor separately about some other issue, but I find it easier to sort of uncouple that from what the patient needs at the time that I'm seeing them personally.
But that's where your notes that you've made come into play.
Right.
That's one of the reasons why we document so much. And in that case, you definitely should document, even though your secretary says, oh, Mrs. Jones, she didn't come back again. So you'll say, well, try to get her on the phone. Let's get her in. And after a while, you kind of forgot about it because time went by. But those notes have to be made and they have to be dated, and you have to make supreme effort to get the patient back. So you send them a certified letter, no big deal, but you really have to do that to prevent this, so you don't get you don't get a summons 6 months later accusing you. It can still happen, but with the backup, you're fine. With no backup, you have a problem. Can't prove anything.
Indeed. You're muted, Julie.
You're muted.
All right, I see that Dr. Plumas has his hand up.
Yes, but I don't have my video on because I'm in my pajamas, so I'm sorry. But regarding this case of the senior doctor with slightly slipping mentally, what I have found is if you talk to the family, they know that dad is losing it, and they're terrified of malpractice cases. So I don't know if going to the physician because of the HIPAA restrictions is great, but sometimes talking to the family really makes a difference because they're very concerned about the collateral effects of that. Other things that came to mind as we were talking about this, the ADA in the clinical practice guidelines, the word standard of care was thrown out, and the ADA takes great pains to say we do not set the standard of care. They specifically say nothing we tell you is the standard of care. So we have to be careful of using the word standard of care when it comes to ADA guidelines. Another question I have ethically is, if this person is not if this doctor doesn't share any patients with us, what do we have an ethical duty? These people aren't our patients then. This doctor may be causing harm, but if these people aren't our patients, do we really have an ethical duty to someone who isn't our patient? I mean, it's more of a philosophical question. And then my last comment is, I believe in New York State, you have a duty to report child abuse, but
Yes.
you have no duty to report the abuse
Elder
of
abuse.
like a woman could come in being battered or
Yeah.
with bad work, but there's no legal duty. In New Jersey, there is. In
No.
New York, there is not. So those are my throw out comments. The big question I have is, if the person who's being harmed is not our patient and we know the other dentist is substandard, do we have an ethical obligation to report that dentist?
Well,
I
you've
think
had
the
to have seen
technical
the
answer
work.
is no.
Yeah, but you're implying that you've seen the work. You've for some reason
No, I'm saying
examined that
that-
individual.
No, the fact pattern I have is the staff from the office of the dentist who is slipping
Oh.
tells my staff,
Mhm.
our doctor is losing it. I don't really have an ethical obligation or a legal obligation, and I'm not sure if I have a moral obligation to stick my snout in that office if we don't share patients together. And that's a question I throw out to the panel. It complicates the fact pattern, but what would you do?
I think if you know that you take the word substandard of care, below the standard of care, if you
No,
know
I never
that-
say standard of care,
okay,
because you can't.
poor care or the patient has been harmed and this is multiple incidences. I think most of us do not want to do it, but yes, I believe that we are ethically obligated to report to the either OPD or some type of a.
Based on what in our discussion tonight says that we're ethically obligated?
My phone call. Today is Tuesday, November 9th at 8:15 p.m. You have my phone number, so I look forward to speaking with you. Thank you. Bye-bye.
So I think one thing we have to think about is our obligations to our individual patients, but also to the general dental public. And so while you may not specifically have a sense of exactly what happened to an individual patient, if you have a staff member of another office coming to you in confidence, I could see how there is some duty to just at least explore that with a conversation, perhaps with their employer, their dentist, just to get a sense if there is something that could potentially be happening, and is there any way that you can help and address this?
Which one of your precepts tonight supports that?
Well, I think it's the concept of wanting to put patients first.
But they're not your patient.
But they're the general public, and
I don't know if we have the right to do that. I mean, this is hearsay from somebody else's staff.
Right.
No, this is, you're assuming that the treatment is inappropriate or there's harm done to the patient. Yeah, without evidence, I don't think we can't report something like this. But if we do have evidence that the patient has been harmed and the dentist is incapable of treating patients, I think we are ethically obligated to report.
Right, but that's a different story. Right. And can I throw out one?
What wrong? You called me. You called me. You know that?
If you're not talking, you could just mute yourself, please. Thank you.
Dr. Connolly, if I still can keep flapping.
Okay.
One more question relating to the previous case.
Yes.
If you know that the patient is going to leave your office without the periodontal care and go somewhere else and get the treatment, what obligation do you have then? So great, you know that you can't ethically treat this patient if they don't want to have perio treatment before ortho treatment. But that patient says, fine, I'll go next door because they're going to they're going to give me Invisalign without perio care. I mean, is that an ethical conundrum for us? The patient is going to be harmed, whether you do the harm or somebody else does it, that patient is going to be harmed. And it's your patient because you've seen them, therefore, you're letting them get harmed by going somewhere else.
I don't think you can stop the patient. I think what you can do is inform the patient of the condition and just try to educate the patient. If you do this, you're not going to get the outcome that you want. And, you know, each person has their own autonomy. If that patient wants to go somewhere else, I don't think you can stop the patient. I think the only thing you can do is educate. And hopefully that message will get through and the patient will find proper care.
Okay, I'll buy that because you cited one of the major tenets, autonomy.
I think you're muted, Dr. Goldsmith. You're still muted.
Okay, can you hear me? Great. I have an example for my good colleagues, very eloquently expressed, his concern about ethical dilemma when the staff, come in and give some informations and you're not actually treating the patient or you have any contact with that colleagues. I give an example to clarify everything. What would you do if you have a new staff and this new staff will tell you that she left Mr. Jones, office because he used contaminated needles from one patient to another patient, and he never changed, needles, he never changed the blades, and so on and so forth. Would you think, you're obligated to do something about it? I tell you what I will do. I will sit down with that staff, and I will tell them under oath, you are confident and you can stand by your word, and you are, as a good citizen, is responsible for that. And after I get the reassurance, I pick up the phone and I call the authority and I report that person. And I tell you something, this is not a hypothetical situation. Back in 1981, 82, when we were dealing with the AIDS, there was a dentist in Florida. He was actually taking the needles from AIDS patients and giving it to other patients. And he was found and prosecuted and put in jail. So my scenario is very, very simple. If you think, something unethically happened and your fellow citizen is being harmed, I think you should report that, whether this is your colleagues or is not your colleagues. I think that's our ethical, responsibility as a citizen. So there's no question that the scenario that you brought up, that this is not our patient, I haven't treated this patient, but I think beyond and above that, as a citizen, we have obligation to protect our citizens, protect our neighbors. Thank you.
Thank you, David. So as we approach 8:30, I think it's time for us to start to wrap up. I don't know if Dr. Cho had any parting words or thoughts that he would like to say about this case or any of the cases that we've discussed.
No, I think this was very informative, very engaging, and I really enjoyed the interaction with the participants. So I thank you very much.
Okay, thank you, Dr. Cho. I want to thank everybody who participated. I think we had a really great sharing of ideas, and I felt that this was a very good forum. If you do have any questions or concerns that arise, you can reach out to Susan Angolia. She is the staff liaison to the ethics committee. And again, Dr. Cho is the committee's chair. We also have several ethics committee members on the call tonight, so I want to thank them as well for their help in putting this together. And with that, I'd like to say good night and also thank you to Susan Apsley and Angolia, who are behind the scenes helping us out and helping us put this together. So thank you.
Consider that. Thank you.
Thank you very much.